Good morning, everyone, and thank you for joining the Superior Health Quality Alliance Nursing Home webinar entitled Advanced Care Planning During the COVID-19 Crisis, with featured speakers Linda Caurdy-Bess and Dr. Carol Robinson. Superior Health is comprised of 8 member organizations across 6 states. Our goal is to collaboratively improve the quality of health and healthcare for consumers, patients, clinicians, organizations, and the communities we serve. Our role in the COVID-19 crisis is to connect organizations to communicate, clarify, and share resources. My name is Julie Bannister, and I will be your moderator for today's webinar. I will be assisted by colleagues Tony Kettner and Candy Hansen. I'd like to take this opportunity to welcome nursing homes in Michigan, Minnesota, and Wisconsin, as well as our stakeholders and partners to today's webinar. Please note this session will be recorded and will be made available to you shortly on our YouTube channel. You may locate this video and others by searching Superior Health QIO. For your convenience, the YouTube link and the link for today's slide presentation are located in the chat. There will be a short survey available at the end of the presentation portion of the webinar. Please note all lines will be muted during the webinar. There will be an opportunity to ask questions during the Q&A segment after our speakers have presented. You may enter questions during the presentation in the chat box by accessing the chat function, which is located at the bottom of the screen. For those joining by phone, to ask a question after our guests have finished presenting, simply unmute your phone by pressing *6 on the telephone keypad. Once you've asked the question, please mute yourself again by pressing *6. Our guest speakers today are Linda Caurdy-Bess and Dr. Carol Robinson. Our first speaker, Linda Caurdy-Bess, received her master's in social work from Wayne State University. With over 30 years experience in the departments of social work and care management in Beaumont Health, Ms. Caurdy managed the Beaumont Royal Oak Social Work Department for 12 years and is currently manager of the Respecting Choices Advanced Care Planning for Beaumont Health. Ms. Caurdy-Bess is a member at large and serves as the chair of the Education Committee for the Great Lakes chapter of the American Case Management Association Board. She is completing her 3-year term on the Michigan chapter of the National Association of Social Workers Board as the Chapter Committee on Nominations and Leadership Representative for Regions 8 and 11. Welcome, Linda Caurdy-Bess. Thank you for joining us.
Thank you so much. I wish I would have known Carol was my co-presenter because definitely I have much to learn from her. So thank you for this opportunity and inviting me to present today on communication skills and advanced care planning during COVID. If you want to go ahead and show my slides.
I'm sorry, I thought the screen was sharing.
Okay, that's okay. So advanced care planning, I'm sure that most of us know, but I'm going to give a bit of a refresher, is always important to think, to talk, to share wishes and preferences for future healthcare decisions. However, this planning is even more important during the pandemic. Advanced care planning is important for adults, for everyone ages 18 and over. Again, it's about planning for future healthcare decisions. And thinking about this in light of the fact that emergencies happen, things that are unpredictable can happen, and that this is important to do this planning while you're well and not under crisis, which is a challenge at the current moment. Advanced care planning is a process. It begins with a conversation. You share your goals and your goals of care and treatment preferences. If you were to become so sick or injured, you could not communicate for yourself. And it's person and family centered. It involves choosing a patient advocate, and that's what it's called in Michigan. In some states, it's called a healthcare agent to make healthcare decisions for you. And it allows you to put your wishes in writing by completing an advance directive legal document. So that's been one of the challenges during this current crisis, the putting wishes in writing, because in some states, well, in all states, the witnessing or the notary requirements have been a challenge. And some people have been very creative in figuring out ways to meet those requirements. And I'll talk about a little bit more later. So I'm going to briefly discuss the differences with advanced care planning, a DNR order, and a My Post or Post. So advanced directive or advanced care planning, also called the durable power of attorney for healthcare. An advanced directive names the patient advocate or agent. It describes specific preferences. It's only used when you become so sick or injured you cannot communicate for your wishes yourself. And it can include optional documentation regarding treatment preferences. A do not resuscitate order is a medical order, and it's completed by a physician or a provider. It informs your healthcare providers what wishes, what treatment preferences you would want. For example, well, mainly about CPR if you are found to be not breathing and not having a pulse. It's easily interpreted by healthcare professionals, but it's specific to the setting and location it was created. So when a DNR order is written in a hospital, that order does not follow the patient into other settings of care, and it does not appoint a patient advocate or agent. And then the My Post or Post. In Michigan, it's the My Post. This is a medical order for people with advanced illness, those people that you would ask the surprise question. You wouldn't be surprised if based on their current medical condition, they were to die within 1 year. It's completed by a provider, a physician, nurse practitioner, or physician assistant. I'm sure that there are some also rules and regulations in different states. Requires a signature from a patient in Michigan and or the patient advocate or legal guardian. It includes treatment preferences, CPR and other medical treatments, and it's used as a tool to direct emergency personnel. It crosses settings of care, and it does not appoint a patient advocate. So the laws and regulations regarding the post or post are state dependent and should be researched for your site and for your state. So as an example, in Michigan, the My Post legislation has passed, but the implementation has not occurred. There's currently some legislative issues with the licensing and regulation bodies. So communication skills in action. The current pandemic has highlighted the importance of communication skills and connecting. For many patients and their families, communication has been limited during this time. For example, once the visitation restrictions were put into place, limiting visitors, the preserving of PPE, and the challenges with trying to conduct family conferences, team meetings, and patient interdisciplinary rounds. So patients and families, they're scared, they're vulnerable, they're not sure what's going on, and we have to be even more attentive to ensuring that we are making those best efforts at keeping them involved and communicating during this time. And for us at Beaumont Health, as an example, the pandemic, once we had our first patient, we were pretty quickly inundated with patients. And at a point where it was difficult to be real proactive, it was almost a reactive state because of the volume and the severity of what we were seeing. And so as time has come along, we've come up with the options of iPad connecting and appointing patient liaisons, because once the provider is all gowned up and ready to go into a room, answering a phone call is a challenge. And so all of that was worked out as we progressed through the crisis. So for some of you, this is the perfect opportunity to be pre-planning for things like this. How do we keep patients and families informed? Again, they're scared, they're vulnerable. It's important to recognize and validate their feelings and to share what we can do before what we cannot. And this was real important, for example, with when we needed to restrict visitation. So instead of saying that we couldn't allow them to visit, what were the things that we could do by allowing them to video connect, etc. to provide transparency and the why behind decisions, and to reassure them and thank them for their understanding and to acknowledge their feelings. This time, communication skills are even so much more important. And I believe that Carol's going to talk more about communicating during a crisis. So respecting choices, which is the model that we follow here at Beaumont Health, came up with a guide to use in advanced care planning conversations during the pandemic. I know that there has been much hesitancy for some to initiate the advanced care planning conversations at this time. They didn't want to alarm patients or residents. We heard many stories, however, highlighting the importance of this planning. And I think it's like when we talk about, if we talk about the person who died, we're going to make people sad. Well, they're sad anyways. So if we talk about planning for future healthcare decisions during the pandemic, we're going to scare people. They're scared anyways. So I think recognizing that is really important. Right now, more than ever, people are reflecting on their life values, what kinds of treatment they would want in the event of a medical crisis, and who they would want to speak for them if a time came when they could not speak for themselves. That during this time of uncertainty, this is something that we can control, who we would want to speak for us. The conversation should focus on what is important to a person, focusing on, is independence important? Is time with family? Living as long as possible? What they consider living well, and not whether they want to be treated with a ventilator. So these discussions will provide the context for decisions. So in the guide that Respecting Choices put out, they talk about introducing advanced care planning and advanced directive terms, making sure that we're asking patients or families or residents to tell us what they understand so that we're using that teach back technique and we're assessing their understanding, to provide information about how to choose, for example, a patient advocate or agent, or when that person would step into their role, emphasizing, empathizing, and addressing any fears or concerns, exploring their understanding of COVID in particular, but also previous healthcare experiences they may have had, goals, values, and preferences for care, and reflecting about what was learned and what matters most to that person, what living well means. And then summarizing and creating a plan, documenting these conversations, and if necessary, completing an actual document, a medical order or post. I have to say that for us at Beaumont Health, and I'm sure for many, completing the actual document in the midst of the pandemic was really challenging. It was challenging because if the patient was a person under investigation or COVID possible, we really had to limit the number of people in the room and even the number of times in the room that staff were able to go into the room. And we didn't want to bring in documents and pens, etc. And so we were really challenged, but what we focused most on was those robust conversations that we could have and documenting those and using them as guidance. So a valuable lesson that we learned, but we continue to learn about the state's requirements and waivers, such as the Michigan Executive Order for Real-Time Audio-Visual Document Witnessing. And we approached this with our legal team, and we made a decision about how we were going to proceed. And I think that that's something that everyone should think about. Are there executive orders? What are the witnessing requirements or notary requirements? And then what is your organization's recommendation and direction? So during this pandemic, the acronym CALMER has been used to guide these conversations as well. So I know that for some of our primary care physicians, they're really trying to be proactive with patients during telehealth and having conversations so that should that person experience a medical crisis, they'll be better prepared and the provider will know what their wishes and preferences are. And hopefully that patient will discuss those decisions or wishes with their family as well. But calmer, the C is check-in. How are you doing with all of this? A is asking about COVID, what they know, what they understand, what they're worried about. L, laying out the issues. Is there something you want to tell us if you were to be diagnosed with COVID? M, motivating them to choose an advocate or an agent and talking about what matters. E is for expect emotion. I think we have to recognize that these are really hard things to think about and plan for, although so very important. And finally, record the conversation. So R, summarize and document the conversation. In particular, the completion of documents due to witnessing and notarizing barriers heightens the need to preserve the conversation for guidance. So coming from an acute care setting perspective, the hospital setting and the skilled nursing settings, those witnessing requirements were definitely and continue and have been a challenge. And so what we're really focusing on, again, is that robust conversation and preserving that in our documentation so that we can use that as a guide. Another example of an executive order in Michigan, one of the executive orders relating to residents and transfers from nursing homes was that all unstable skilled nursing facility COVID patients must be admitted to the hospital unless they have an advance directive in place that specified whether they would want inpatient treatment in a hospital setting or hospice services. And so this could also be another motivator for residents and patients to begin to think about whether they would want that, whether that's the care that they would want to receive. And if not, that they would want to have some documentation about those wishes and preferences. So as we've rolled out respecting choices across our Beaumont Health settings, which are 8 acute care campuses, many ambulatory physician practices, and 2 skilled nursing facilities, one of our pilot sites was our skilled nursing facility. And during the implementation in August, they began stratifying their residents into those that would benefit from palliative care services. And then of those patients, they noted whether they had an advance directive in place. If they do, they revisited that document to see whether it was in alignment with what their wishes were at that time. And if they did not have a document, they looked at whether that patient had capacity to complete one, and if they did, offering those services. So this proactive approach actually ended up being really helpful, unbeknownst to all of us with this current crisis, because it helped them to target patients. I know that when patients or residents are admitted to a skilled nursing facility, they're asked about advance directives, but if someone declines wanting assistance with that, you know, how often is it revisited? Is it a more robust conversation? And we found at our facility, at least, it wasn't necessarily that way. It was sort of like, oh, we checked that box. But so this gave us the opportunity to have more targeted conversations about who would benefit from these interventions. And during the current crisis, they further targeted patients to identify who would want to be hospitalized. And those that would not, they're getting a medical order in place. So they're having robust conversations about the current crisis and what their residents' wishes and preferences would be and following that up with a medical order so that staff know how to intervene should something happen with that patient. And then, of course, making sure that there's communication with the resident's family if appropriate. The importance and why. So we all are aware of the unpredictability of COVID-19, that patients can deteriorate so quickly. And according to the World Health Organization data, the average death rate among elderly patients ranges from 15 to 22%, which is 5 times that of the general population. And I know that early in the pandemic, the focus was on the elderly and those vulnerable with chronic health conditions. But we've seen that all ages have been affected, and some with really poor outcomes that were not initially expected. So I go back to that statement about this is a conversation we should have for all adults 18 and over. One of our physicians is documenting her experiences during the pandemic in COVID-19 diaries. And she wrote that her patients ranged in age from 18 to 103 that were COVID positive. And of the 55 patients that were under her care, only 1 had an advance directive. And she further talks about her moral distress in not knowing the person and their preferences and wishes. But not only is the provider unaware, but without advanced care planning in these conversations, those closest to the patient, their family and their friends are also unaware and are struggling. So the advisory board put together some barriers that nursing facilities might have to advanced care planning and ways to address them. This is the time to know your resources within your organization and your community, and to recognize that it takes a team, that advanced care planning is a process. And some of the barriers are regarding staff discomfort. Do we need to provide them with education and tools so that they can have these conversations? Time, everybody talks about this takes time, and it does take time. But you can partner with organizations, particularly palliative care programs or other organizations that deliver advanced care planning services. Reviewing existing documents. So it's important, as I pointed out earlier, to revisit plans that people have in place, especially in the context of COVID-19. And then lack of access to families. So that kind of goes back to some of the barriers with witnessing, but also not having access to families and ways that we can be creative to connect with them virtually by phone or with video conferencing. We've had experiences as well of patients being admitted to our emergency centers really bad off because people are delaying receiving care. They're so fearful that when they come into the hospital, they can't communicate. And this is at a time where families aren't at the bedside. And so there's really a loss. And so, proactively talking about, okay, so if we don't have an advance directive in place, we need to have some kind of way to provide some written documentation so that healthcare providers know who to go to have conversations and learn more about you as a person and your wishes and preferences. So also, CMS is currently allowing advanced care planning to be delivered through telehealth, and they recently authorized audio only, and this allows equity and equal access to this important process because many people, especially elder and those of lower socioeconomic status, don't have the ability to Skype or have Zoom meetings. They may not have smartphones. And so that's really an important decision that was made during this time and very valuable, but more work needs to be done to address other barriers, such as the witnessing of signatures, the notarizing, the cost sharing when a provider has these conversations, expanding the kinds of providers who are eligible to be reimbursed would also allow this to be a more equitable service that's offered, and ensuring that a person's advance directive travels with them and is honored across state lines. So we still have a lot more advocacy work to do. As a final note, we often address advanced care planning for others. Many of us in healthcare have not considered our own mortality. And the best way to lead is by example. So April 16th of every year is National Healthcare Decisions Day. And this year, most of the efforts in this regard were limited because of social distancing, et cetera. So July 16th is being considered a National Healthcare Decisions Day 2.0. And I hope that all of you will join me in promoting this important work with the patients and residents that are under your care and with the providers. So we should lead by example. And I put together some brief resources. There are plenty, but this will give you a starting off point. In conclusion, I just want to recommend the following to support your work. Know or develop your organization's plan. The document that you use, the advanced directive document you use or plan to use, who will be involved, and what type of education they might need. Know your state's rules and regulations regarding advanced care planning and advanced directives and any executive orders in place during the pandemic. Know your partners in the community and who else is available to partner with you. I think this is the perfect time to look outside of your usual sources and think about joining with some partners that you haven't, or some organizations that you haven't partnered with in the past. Network with your peers and share ideas, processes, and best practices. Take advantage of the resources that are available that you might not normally have access to. For example, some of the resources on the Center to Advance Palliative Care, CAPC, and Respecting Choices, etc. And then again, be kind. None of us has experienced anything like this before, and we are all learning as we go. And so everything that we learn along the way is valuable and adds to the knowledge that we can all take with us moving forward. And so just a little quote about things to remember about storms, that they can be scary and chaotic. They can cause us to slow down. They can make trees take deeper roots. Rainbows often follow, and they won't last forever.
Thank you very much. Thank you, Ms. Caurdy-Bess, for sharing that valuable insight and the importance of advanced care planning. Just a reminder, you may enter questions during the presentation in the chat box by activating the chat function, which is located at the bottom of the screen. And then, Ms. Caurdy-Bess, if you would like to stop sharing your screen, I do have one of my colleagues who's going to get us back on board with the slides. While we are getting queued up there, our next speaker is Dr. Carol Robinson. She has a varied nursing career in both clinical and administrative leadership positions. Her clinical specialty is with children and adults with life-limiting pulmonary disease. Sarah, if you don't mind advancing that screen, thanks. Dr. Robinson has earned her Doctor of Nursing Practice for Health Systems Leadership from Grand Valley State University. A certified hospice and palliative care nurse instructor, Dr. Robinson is also a trainer for the End-of-Life Nursing Education Consortium. She has extensive experience with patient and family communication relative to quality of life and treatment preferences. Dr. Robinson serves as the Community Engagement Organizer for Making Choices Michigan and has served as a Respecting Choices Advanced Steps Advanced Care Planning Facilitator. She is currently serving as a Respecting Choices First Steps Advanced Care Planning Facilitator and Instructor. Dr. Robinson's scholarly work focused on communication skills for health professionals, including advanced care planning conversations. Good morning, Dr. Robinson. Thank you for joining us.
Good morning. Thank you for having me. And thank you, Linda, for that wonderful overview, because that was just what the doctor ordered. No pun intended. So we're going to go ahead and get started here. If you want to flip the next slide. Just a little bit about Making Choices Michigan. We're a nonprofit arm of the MyHIN group. That's the Michigan Health Information Network. And we were established in 2010 to move the conversation about serious illness as well as well adults and advanced care planning out into the community. So we've been doing that actively for about 7 years now, engaging people 18 and up. In the past year, we've reached over 1,000 college students. So we're really trying to get people to talk about what matters most while they are well. And then this becomes a conversation that lasts a lifetime, just like Linda was talking about, that you can update this throughout your lifespan. If you can flip to the next slide, please. So we're going to talk about useful conversation and decision aids and also techniques to promote goals of care. And so flip, actually, I'm saying I should actually share the screen and I can do it for you, but so you can flip again. The first up is an article that just came out within the past week by Diane Meyer, who's well known in the palliative care community. She's at Harvard and Boston Women and Children's. And what she's been finding with her experience with COVID is been my experience with people with advanced illness, that while we're concerned about having the conversation, most often people are actually grateful and relieved that we've brought it up because they've been thinking about it, exactly what Linda was saying. Sometimes it's just nobody has ever asked somebody what's most important to live life well. So that's a great little one-pager that you can read online by Diane Meyer. And I do have the links to everything that I'm going to talk about today within this presentation so that you'll be able to click on them and read it. So if we go to our next slide, Linda had mentioned respecting choices. And so right now, they are making a lot of their tools available to people like us through June 30th at no cost. And so people that have already gone through Respecting Choices facilitator training at any level will be familiar with some of these tools. But these are really great conversation guides about talking with people that are well adults, talking about people who have serious illness, and then also additional tools for COVID-19. The bottom of it says tools to support specific treatment decisions. And so those are what we call the decision aids. And it's really interesting, you know, the directive we have on the Making Choices Michigan website was community created. It's in its 4th iteration. We've had it for about 6 years now, made with the input of physicians, nurses, social workers, chaplains, patient advocates, people out in the community. And it's at a 7th grade reading level. But we're actually having to redo it soon because the average reading level now is down to 5th grade. So it's really important to think about not only healthcare literacy, but also numeric literacy. And the decision aids have good information on the front page in words, but in the back it's got pictographs. So when you say, you know, somebody that's an older adult has a 15 to 22% chance of surviving COVID infection, not everybody knows what you're talking about. But if you flip it over and there's like 100 little marks there and 15 are darkened, that says this many people out of this whole big picture. And I think that's really something that we have to seriously consider right now. We tend to use a lot of clinical language with patients and they don't always get it, and especially if they're stressed and or sick. Next slide, please. So the conversation guides also include handouts for why you would want to do proactive care planning for COVID-19. So that's the little form on the right that you can give to somebody about if you want to, especially for your family members too, of your residents, if you want them to have a nice opening about this is why we're talking about this. And on the back side, which is the little one on the left, that includes some questions that would be important to ask family members if the person has lost their capacity to make decisions for themselves. But it works for both. And like I said, this is a free resource that's available through June 30th. So you really might want to look at that. Next slide. So this is what I call the treasure trove. It's the conversation project. This was started a number of years ago by Ellen Goodman, who's actually a journalist, but she started the conversation project after traveling the journey with her mother of a serious illness and sometimes the actual lack of conversation that was going on. So I have used this tool about 9 times now in the past month with people with serious illness, because it has really great questions about what would you specifically want to do with COVID diagnosis. So this is really not for the long haul. That could be a post document in Michigan or post in our other states, but specific to COVID. So for example, I had a couple that wanted to revisit their directive. He has Parkinson's disease. They're in their mid 70s. She's healthy, so she's the one that takes care of grocery shopping, all these types of things. He said, you know what? I would not want to go in the hospital for COVID because I already have a pretty advanced illness. I don't think I'd survive it. He said, and plus I'm an introvert. I really wouldn't want to be on any sort of life support. It's more important to me that I am home and with my family if that's what's going to happen. So that's how we filled out this tool for him. His wife was the opposite. She goes, I'm pretty healthy. I think I could survive it. And I'm willing to take a chance. So, you know, she filled out hers totally different and she'd be okay with the iPad communication. So that's why it's so important to really walk through these questions, but the conversation project makes it very easy. I highly recommend you visit this site. They started out with the basic conversation project guide. And then the one that we've been using for the past 2 years is also one for people with dementia. So in the skilled nursing facilities, residential homes, that one is also so important. So please, please, please look at those, and you can also find them on our website. Next, please. Okay, this one is just downright fun. So I've been a palliative care certified nurse for 20 years, but been doing it long before when we didn't have a name for it. I love the Vital Talk app. You put it on your phone and you're off to the races. It's got all sorts of great cues for regular conversations with what now I call regular palliative care conversations. Oh my goodness, we used to think they were so tough. Now it's the ones about how you break serious news. What are your goals? What are late goals? What about what family says? And on every single screen, you can flip, it's almost like having a little playing card. You can flip it to the other side. So listening for the emotion, and then what do you talk about based on what they bring up. They have added now COVID questions, which are very good. So everybody should be popping that onto their phone and play around with it, talk about it within your staff meetings, et cetera, because there'll be something for everybody on this. Next slide, please. So I did mention Making Choices Michigan. We do have a directive on our website, and we also have the patient advocate guide, because a lot of people, especially in other states, in Michigan, you have to sign the directive that you agree to be the advocate, but not all states roll like that. So I always tell people it's a job. It's not, you know, mom likes you best. This is who can actually do the work of being an advocate. We also have a resource page for you of important questions to ask when you're dealing with the healthcare team. I always say you don't want a shrinking violet as your advocate. You want somebody that can ask good questions. And so we use a series of questions from the American Board of Internal Medicine for the Choosing Wisely project, questions from Ben Carson of Choosing Acceptable Risk, and then a Atul Gawande with decision-making and serious illness. And those are all available at the website. If you want to flip to the next slide, please. So the goal, and this is so important, how many of us have been in a patient's room and heard a doctor come in and say, do you want us to restart your heart if it stops? And I always just like go, oh, face palm, please, here we go again. It's not about the process of care, which for the DNR conversation is about the process of CPR. It's about the outcome. You know, it's not surviving the attempt as much as it is with what would a person be left with if they do survive the attempt? What type of function are we talking about? And that's one thing that it's really important to think about with the residents, not just for COVID, but even dementia in general. I experienced this a year and a half ago with my mother-in-law. She had advanced dementia, lived with us until it really wasn't safe for her to be in the home anymore. We moved her to a memory care unit, and she was in late stages of Alzheimer's by that point. So she was falling more. She was hardly ever awake, all those types of things. And I got a call one day that she had fallen, and they said, where do you want her to go? And I said, well, I want her to go back to her bed. And they said, you don't understand. She's EMS is already here. She's on the gurney. Where do you want us to take her? I said, I want you to take her to her bed. And they said, but a doctor walked by and said she might have had a stroke. I'm like, maybe. Take her to her bed. I said, she's got an advance directive. She's got the dementia directive. She's been very clear she wants to die at home. You are her home right now. That is where she wants to be. And the nurse, and she meant this, I've said this in the past. It just hit me like a ton of bricks when she said it to me as a family member. She said, oh, so you don't want to do anything? I said, no, I am doing something right now. I'm honoring her wishes. We're referring to her directive. She wants to die at home. Home is you. And I said, put her in her bed. I'll be there within the hour. And I said, and we'll call hospice, you know, if that's what we need to do. And that is what we did, because the staff needed somebody to call besides EMS. They needed to have a resource. I understand that, the regulations that they're under to make sure they're providing adequate care, but we certainly didn't want her to be hospitalized for something that she never would have wanted. You know, she told me before her dementia really advanced, she said, you got to die from something. And for her, she preferred a stroke or whatever. And by the way, she didn't have a stroke. It was just another one of her very sleepy episodes where you couldn't wake her up. So there you go. Next slide, please. So if we move knowledge into action, next slide, we're going to talk about code switching. So instead of you don't want to do anything, right? I wish what the nurse would have said to me, and now what I would say is, you know, that's a really well thought out decision, and we're happy to make that happen for your mother-in-law. If you want to just keep them clicking, so instead of saying end of life, I want people to focus on goals of care. Instead of saying do not resuscitate, I want you to say, would you like to allow a natural death? And instead of having these pop quizzes in the emergency department of the ICU, quick, what are we going to do? If we've had this planned conversation, then it's very easy to recenter the family and get them back to on track of what the person wanted. Next slide. So to get the ball rolling, here's some additional questions from the conversation project. You know, when you think about your last phase of life, what is most important to you? You know, for some, it's being at home, like my one gentleman. What particular concerns do you have about your health right now? I hear a lot of people talking about, well, if I had COVID, blah, 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 blah. How active do you want to be in the decision making? Sometimes that's a real cultural issue. For some groups, it's more what we call relational autonomy instead of individual autonomy. Our laws are written in the United States for individual autonomy, but in some cultures, it's very important that the whole family weigh in. Are there circumstances that you would consider worse than death? You know, yes. For my mother-in-law, it was going to be being in an ICU, being hooked up to stuff. You know, she was like, why would anybody want that? And are there disagreements or family tensions you're concerned about? I hear about this all the time in our general conversations when I talk to people. You know, well, I want this, but I know my one son is really going to give me trouble. I say, well, then let's get him on the phone and let's involve him in this conversation so that we can all talk it out now in a nice, calm environment. But it's better to get it laid out on the table. Next slide, please. So this is an article I read last week in the Washington Post, but it had been reposted. It was originally posted in 2019 around Thanksgiving time. It says doctors are torturing dementia patients and their end of life, and it's totally unnecessary. And he's actually gotten pretty straight up with families now. So do you want us to do procedures that may well be painful? They're not going to improve the quality of life, or would we want to let her go in peace? You know, sometimes recentering it. I had this conversation with a cousin 3 weeks ago about my 92-year-old uncle, where she's talking, what if he ever gets sick and he might need dialysis and things like that? I said, no, he wouldn't, because he wouldn't do it. But it was hard. You know, the big thing was, it was kind of like the whack upside the head of, oh my gosh, he's 92. He's not going to live forever anymore. You know, it's kind of that, let's just recenter here for a little bit. Next slide. So if you've never read Being Mortal, and who's got time now, but it is definitely worth the read. The whole first half of the book talks about aging and dying and how we do it well and how we don't do it well. The second half is more about serious illness. So when he says hope is not a plan, you know, we hear a lot about hope. And I hear doctors and other providers sometimes saying, well, I don't want to take away her hope. I say, well, have you asked what her hope is? What is this person hoping for? How often do we ask that? We just assume that hope means they want everything done. So these questions are really good to get centered on what does a person really want? And if their current condition worsens, what are their goals? So for my gentleman with Parkinson's, it was stay at home, you know, have his family around him, start hospice. What are you afraid of? What's most fearful? Are there trade-offs you're willing to make? I've seen in my career, people switch gears sometimes. At first, they don't want treatment, and then all of a sudden it's full court press because now they've got a kiddo who's pregnant and they want to live long enough to see that baby be born. You know, so people can change their mind. And then I always ask, what does a good day look like right now? And as they progress down the road, I always ask them, is this still a good day for you? Where are we now? Next slide, please. Finally, with Ben Carson, he wrote a book in 2008 called Take the Risk, Learning to Identify, Choose, and Live with Acceptable Risk. And he's a pediatric neurosurgeon. He's now our HUD secretary, but for years, that's what he was famous for, is the first to successfully separate twins conjoined at the head. But I loved his approach with parents because he was doing the one hand, other hand. If we do this, what is the best? And I always add realistic outcome I can expect. And what's the worst realistic outcome if we do this? And then on the flip side, if we don't do it. Because I think people in a crisis hear two, not four of these. They hear what's the best I can expect if we do it, and what's the worst if I don't. And there are two very other important questions in the middle of what's the worst I can expect from this if we do it. And for some, that's on event 3 weeks or whatever. Might survive, might not. The implications of that is, these are just great questions to help people weigh it out and to help the doctors really explain a true informed consent. You can go ahead and flip. So that is a nice long list of some of the resources that we've been talking about at Making Choices Michigan with our patients all along, but especially during the times of COVID. And I think we have a few minutes because I wanted to see if people had questions. It's a lot of material to cover in a short time, but the resources are great to dig into.
Thank you, Dr. Robinson, for the timely and relevant discussion around end-of-life conversations. We would like to open up to questions. Please complete the short survey available in the chat. If you are joining by phone to ask a question, simply unmute your line by pressing *6 on the telephone keypad and then press *6 to remute. Do we have any questions in chat at this time?
There is one question that's come in. How would you deal with family members who may not agree with your decision about treatment choices for COVID?
Sure. And I will say, if they don't agree with my choices, I don't know if that means that I still have capacity or not. But that's the beauty of these conversations we have, is if you've got the advocates present, you can talk about these differences of opinion all the time. We hear it all the time, but you've got a chance to talk about it then as what concerns you most, what are you afraid of, those types of things to actually get at it. It's like the family member I was talking about that didn't agree that Dad should not want to have all these things and should allow a natural death. It was like, we've got to quote unquote fight. And I do ask families and patients sometimes when I hear the fight language, I want to say, well, what are you fighting for? Because a lot of times it's quality of life. It's not full court press. But just call the elephant out that's on the table. Find out what the real concern is about that. And Linda might have something to add as well.
Well, I think in the acute care setting, what we're always talking with our physicians about is that you're the provider offering best medical practice. And so you don't necessarily get to choose something that isn't part of what's being proposed by the provider. You know, and sometimes physicians need a lot of reinforcement about that, and families as well. You know, like, I can't say that I want an MRI because I just want to be checked if a physician doesn't think that that's appropriate for me. You know, so there is some guidance that providers, you know, need to give, and setting some limits. I think, as Carol said, the best way to avoid all of that is the proactive planning, because then we really know what's important to the patient themselves, not about the family member or the relative. And I think there's another question. If you are an event, are you unconscious for that time period? Yes, you are. And so we even talk about that sometimes when you're thinking about who you would want to represent you, should you be unable to, it can even be during a short time period.
Right.
It's like, it doesn't mean that you never regain capacity. Many times that is in fact the truth, but it doesn't necessarily have to be that way. Even people who undergo surgery during that time, you know, anything could happen. You know, have you thought about who would be the person, and have you talked to them about what's important and what your wishes and preferences are? I think we make a lot of assumptions. So Carol talked about, I don't know, an uncle. I have a 102-year-old grandmother who had her 102 birthday on April 18th.
Oh my goodness.
And, you know, like, God love her, she has no chronic health conditions, but we've been very proactive about knowing, like, yeah, she's really good now. She's not always going to be. It's a delicate balance. She's 102. Should something happen, it's going to impact her really, really hard. And so she will go from being okay to not being okay. And so, like, I constantly am having that discussion with her daughter, who's her representative. Like, we need to be thinking about this, and we need to talk to grandma, because just because she can do these things now, she won't always be able to. And so you're going to make different decisions when you realize that the trajectory is much different.
Mm-hmm.
Thank you for that perspective. One thing that was said, staff need resources and education. I almost feel like staff also needs forgiveness from following an expected or traditional plan of care. Is that sort of conversation or that content within the resources that you provided?
Say that again.
I feel like the staff who want to follow a traditional or expected plan of care, that plan of care that we've, you know, I'm a nurse, you save that patient at all costs, right?
Right.
How can we work with them to not only have resources and education, but that sense of forgiveness that it's okay to follow a resident or a patient's directive and not what is expected of you as a healthcare professional.
Right.
And are you talking about, well, it's hard to know who wrote it, because that can go either way. Some people don't, they do want the full court press. But I tell you, I've done hundreds of conversations now, and that gets extremely, the older the person gets. I just don't see that. But I think there should always be forgiveness and talk amongst staff. It was just like when that nurse said to me, I mean, she said it very kind, but so you don't want to do anything. And that was, I know that I've said things like that in the past. And you think you're being supportive, but the way it comes across is not supportive. If I would have been a little 86-year-old spouse, I would have been like, oh my gosh, I'm not doing the right thing. I should be doing all this, because I've been questioned by somebody in authority. So I think it's really important to have conversations between team members about how they do communicate and how they can code switch and change their conversations. And yes, be kind with one another about how they've done it in the past and the learning that comes in the future.
Thanks for addressing that. Oh, I'm sorry.
Right. I mentioned that as one of my last bullet points about things to think about and support your work is to be kind. And I think even more so now, but I think that we should always be kind. And advanced care planning isn't to further anyone's agenda except to learn the wishes and values and preferences of our patients. And to respect and honor those to the best of our ability. And sometimes that may be challenged because of this pandemic, as an example.
Yes.
But to be kind to each other and to recognize we're all doing the best that we can.
Right.
Thank you. On behalf of Superior Health, special thank you to our guests, Linda Caurdy-Bess and Dr. Carol Robinson, and participants. Thank you also for attending. As a reminder, the session has been recorded and will be made available to you on our YouTube channel. You may locate this video and others by searching Superior Health QIO. For further information and resources, please visit our website at www.superiorhealthqa.org. And this concludes our webinar. Thank you so much.